So I want to thank Ender and Nirab for inviting us. My name is Meritxell Bach, and I'm head of the Medical Image Analysis Laboratory at the University of Lausanne and at the Center of Biomedical Imaging. And well, I have a lot of applied projects on medical imaging. We work with reconstruction, in the past more registration, segmentation, and my motivation is really to develop still new methods, but really motivated by clinical needs. And a very good example of this is the project of Francesco. So Francesco, he has a bachelor in physics and your master in applied physics, correct? And from the University of Bologna, and he joined the group 2 years ago, or 3, I don't remember.
3 years ago.
Yeah. 3 years ago, yeah, time is flying. And he's doing his PhD in the context of the European project TRABIT that actually is focused on the translation brain imaging techniques. And well, I will give the floor to Francesco, that he's really doing a lot of things on multiple sclerosis in order to support the extraction of advanced biomarkers and features from advanced MRI sequences. And yeah, Francesco, go ahead. And if you want to say something more that maybe I missed, I was not planning to.
Thank you, Mary, for the nice introduction, and thanks, Ender, for the opportunity to present today. So yes, I'm a PhD candidate, actually co-supervised by Jean-Philippe Tiran at EPFL and Meritxell Bach at UNILSHUV. And so today I'll present our work regarding the translation of MP-RAGE to MP2-RAGE uni in order to improve the segmentation of MS lesions and tissue in MS patients. So our work was recently accepted in Computers in Biology and Medicine, and I will briefly give introduction of the clinical context of MS, then explain briefly the MRI contrast we are using, and mention some related works, and then dive into our method, its evaluation, results, and conclusions. Feel free to interrupt me at any time. I'm happy to take any question, and then of course you can discuss at the end. So multiple sclerosis is a potentially disabling autoimmune inflammatory disease which affect the brain and the spinal cord. Its process is initiated by T cells, which trigger an autoimmune response against the myelin sheaths of neurons. This causes a progressive inflammatory response, which ends up in an axonal loss or even necrosis. Here on the right-hand side, we can see an example of a nerve which is affected by MS, and the myelin sheath is clearly damaged. Different types of MS have been identified by international consensus. And however, there is, as of today, no cure for MS, and several treatments can only slow down its progression. Worldwide, MS has an incidence of more than almost 3 million people worldwide, with a prevalence in the Northern Hemisphere, as we can see here on the right-hand side in the map. And there is actually no clear cause regarding the triggering mechanism, even though some hypotheses have been made regarding environmental and genetic factors. And this brings us to the fact that an early diagnosis is extremely important. And today, MS is diagnosed based on a blood test, on a spinal tap, and of course on MRI. On the left-hand side here, we have the neurofilament light chain, which is the one we examine with the spinal tap. And on the right-hand side, MRI images with conventional and advanced contrast, which I will explain in a second. And MS causes these lesions in the brain, which are distributed as shown here in the image. In particular, we can classify MS lesions in white matter ones, as the ones which affect only the white matter, and cortical lesions, which are the one which interest as well the gray matter. The lesion dissemination in space and time is a diagnostic criteria of MS, and therefore their detection and segmentation is extremely important. Regarding MRI, this is of course the imaging technique of choice to visualize MS lesions, and they can appear here, as you probably know, as either hyperintense or hypointense, depending if the contrast is T1 weighted or T2 weighted. And in the literature, most of the image analysis techniques have been focused on the analysis of the white matter lesions, which are the most well-known and spread biomarker of the disease. Recently, however, some advanced or specialized MRI contrast, such as the MP2-RAGE and the DIR, have been proposed, and these can be extremely useful to analyze advanced biomarker. Here I propose 3 examples of advanced MRI biomarkers, which we have been analyzing in our group. So starting from left to right, we have the cortical lesions, which seem to correlate with the severity of the impairments of the patients. Then in the middle, paramagnetic rim lesions, which consist of a prognostic biomarker. And finally, on the right-hand side, the central vein sign, which is a biomarker which helps differentiating MS from mimic diseases. And from all 3 of them, we as other groups have proposed automatic or semi-automatic tools which with the aim of helping their automatic detection or segmentation. Focusing on the MP2-RAGE contrast, this is a T21 weighted contrast characterized by the acquisition of 2 images at different inversion times. These 2 are then combined with these very simple formulas, which yields as output a uniform T1 weighted image, which has a really nice gray to white matter contrast, and also a T1 map, quantitative relaxation map. This is, of course, a Siemens sequence, but Philips has, however, an equivalent one with a different name. So what's the difference between MP-RAGE and MP2-RAGE? MP-RAGE is the commonly acquired T1 weighted sequence in the clinics, and has a shorter acquisition time, and is usually very well spread and well known. On the other side, the MP2-RAGE uni has proved to have a higher tissue and lesion, MS lesion contrast, has a reduced B1 bias field, and very importantly has a higher sensitivity to white matter and cortical lesions. And this was explicitly shown by visual analysis of radiologists. So the goal, yes, of our paper is, of course, to translate these commonly acquired MP-RAGE images to MP2-RAGE ones with a generative adversarial network. I'll briefly do a parenthesis on some previous related works. As you well know, there has been a lot of works applying GANs in medical imaging and in MRI especially, translating one contrast to another, or even cycle GAN generating CT or MRI from the other modality. However, I want to focus on 2 works which tackle MS images. So in particular, Salem and et al. Proposed this method to synthesize MS lesion as a data augmentation techniques. And this was a way of increasing the training dataset for a supervised CNN. And they show that this can improve the performance. Another method, which you might know well, is called Diamond GAN, and was previously recently proposed to generate synthetic DIR images. And the author showed that experts couldn't distinguish actually the generated DIR from the real ones. So these are extremely interesting results. One point here, however, is that generating an additional MRI contrast provides additional information which needs to be visually analyzed by the expert. So this brings us to the goal of this work, which is really to translate MP-RAGE images to MP2-RAGE uni-ones without trying to create new information, but really trying to have a mapping between the two contrasts. And we evaluate this mapping analyzing the performance of two automated segmentation tools, one which segments MS lesions and the other one unsupervised, which segments brain tissues. So regarding our method, first of all, I'll start with our data set. We use images acquired with a 3D Siemens scanner. We have 4 MRI sequences, so a 3D FLAIR, 3D MP2-RAGE, MP2-RAGE, and DIR, all with the same resolution of 1 × 1 × 1.2 millimeters. And we have 12 healthy controls and 44 MS patients with all these patients are in the early stages of the disease. And here I propose the 2 images. So on the left-hand side, you have the common MP-RAGE, and on the right-hand side, the MP2-RAGE. As you can see, they are extremely similar. However, on the right, you can see a higher tissue contrast, particularly if you focus on the cerebellum area, as well as MS lesions have a higher contrast as well. We can see, for example, here would be a lesion. And so, yes, I think these are our images. And okay, our framework is based on the PIX2PIX architecture, which you probably know very well. We only did some modification regarding the addition of residual units in the network. And we also added a global skip connection between the input MP-RAGE and the last layer of the generator. And this is was motivated by the fact that we really want the network to learn the correction between the input and the output. And this was helping also speeding up the training process. On the other side, the discriminator is composed of 5 convolutional layers, which receive an entire 2D slice as input. Our framework is trained with a combination of 3 losses. So first of all, we have the common N1 loss, which compares the generated synthetic MP2-RAGE images with the ground truth. Secondly, we have the adversarial loss, given by the ability of the discriminator to differentiate synthetic and real ones. And finally, we added also a perceptual loss, given by the comparison of the feature maps of the 4th layer of pre-trained VGG16 network. And yes, then we empirically optimize alpha and beta as weighting parameters for the loss terms. Regarding the sampling, we extracted 2D slices from the 3 orthogonal planes of our volumes. We then selected randomly 128 and 64 square patches. The smaller one, the 64 ones, were then resized to the 128 size. We employed some data augmentation as rotation and flipping of the axis. And then those images, together with the 128 squares, were fed to the generator. And so how we evaluated our results? So first of all, we had an image analysis expert with 20 years of experience in MRI, who visually look at the 36 testing cases one by one, examining the 3 planes and looking especially for possible artificial artifacts. We then use 3 commonly employed metrics, such as the PSNR, NRMSE, and SSIM. And then we perform, as I mentioned before, an evaluation based on the automatic segmentation we obtain with these images. So starting with the tissue segmentation, we apply Atropos, which is the unsupervised approach used in the GANs, the very well-known neuroimaging software for brain tissue segmentation. Prior to applying Atropos, we score strip the images, we normalize with N4, and then we segmented 3 main classes, so white matter, gray matter, and CSF. So in this case, we considered the MP2 segmentation as ground truth. On the other side, we also applied our in-house 3D UNet base for MS lesion segmentation. In this case, no pre-processing was necessary. We divided our 36 testing cases of the GAN in 3 folds for a cross-validation. And here we had the ground truth given by white matter and cortical lesions manually segmented by an expert. In both cases, we evaluated the dyes, the volume difference, and for the MS lesions, also the detection rate. So looking at the result, first of all, I propose some visual results. So here on the left-hand side column, we have the initial MP range image seen in the 3 planes. And then in the middle, on the right-hand side, we have the MP2 range and the generated MP2 range. Does anyone want to guess which one is which? So which one is the one we generated and which one is the acquired image? They look similar, but you can get some.
Is the middle one the synthetic one?
Yes, correct. How did you figure it out?
The cerebellum has no noise.
Yeah, correct. So there is an over-smoothing, right? Very slight, not much visible, but there is. And yeah, on the right-hand side, we have the acquired MP2 range. So here I propose some residual images, which I think are very interesting to see actually what the generator is learning. So in the second row, from left to right, we have the difference between the MP2 range and the MP range. So we clearly see that the MP2 range image highlights the CSF and also the cortex, the cortical area, much more. Then in the middle, we have the difference between MP2 range and synthetic MP2 range. This is almost all random noise, besides some really slight indication of the cortex. So this is a good sign. And finally, on the right-hand side, we have the difference between the synthetic MP2 range and the initial MP range. And we clearly see that we increase the delineation of brain structures such as gray matter, also the CSF, and some brain lesions as well. Moving now to the visual analysis. So our expert did identify some artifacts in the testing cases. However, all the artifacts found in the synthetic MP2 range images were then retrospectively found also in the initial MP range image. So starting from the left-hand side, here we can clearly see some motion artifacts, both in the MP range and synthetic MP2 range. These were not present in the MP2 range. And yeah, it could be that the patient was not moving at that moment. Same for the second column. And the third one, the fourth case, however, it's where we have actually some motion in the MP2 range acquisition, whereas our synthetic MP2 range and the initial MP range look much nicer. Overall, we observe only a slightly decrease in bias field in the synthetic MP2 range images, so we were not completely successful in removing the B1 bias field. So moving now to some quantitative results. These are the metrics I was describing before, and So starting from the left-hand side, we have the PSNR, NR, MSE, and SSIM. And for all three of these, we consider the MP2 range as ground truth. So we compute the metric with respect to the MP2 range. And for all metrics, we improve the result compared to the initial MP range. However, for the SSIM, the improvement is very limited. And looking now at some visual result of the automated segmentation, at the top, so from left to right, we have again MP range, synthetic MP2 range, and MP2 range. And in the second row, we have the tissue segmentation results of arthropos ants. And we see that the MP range segmentation is definitely not very accurate in the interface between white and gray matter. And on the other side, the MP2 range ones looks much better. And we see that the segmentation obtained with our synthesized MP2 range is definitely represent an improvement compared to the initial one. The same is more or less observed for the lesion segmentation. So here we have periventricular MS lesions, which is not very well delineated on the MP range, whereas the delineation on the synthetic MP2 range seems to resemble more the MP2 range ones. And looking now on a patient-wise level at some result. So here we have from left to right the white matter, gray matter, and CSF. And in the first row we showed the dice coefficient results. And we applied a Wilson sign rank test. We can see that for all three tissue types, actually the segmentation of the synthetic MP2 range images significantly improve the MP range ones. And the same is observed for the absolute volume difference, where again we see a significant improvement in all three tissue types. Then moving to the lesion segmentation.
Sorry, Francesco, can I ask a question about the previous? Here the ground truth is the MP2 range segmentation, yes?
Exactly, it's a segmentation, yeah, correct.
I see.
So of course it's not a manual ground truth.
Yeah.
We suppose that the MP2 range has been proved before that has a higher tissue contrast.
Yeah, no, that makes sense. So here the MP range having a lower dice means that it reinforces the fact that MP range does not have enough contrast to create the accurate segmentation. Is it?
Exactly. That's
I see.
I suppose. Yeah.
Okay. Thank you.
Of course. So moving to the lesion segmentation, this is interesting. So on the first row, we see the detection rate. On the left-hand side, the white matter lesion detection rate, and on the right column, the cortical lesion detection rate. And in this case, we actually did not observe any any significant difference between the combination of contrast. So we use flare in all cases, and then we combine it with either MP range, synthetic MP2 range, acquired MP2 range, or the IR. And contrary to what was shown previously in the literature, in terms of detection rate, we did not observe any significant difference. Moving to the second column, here we have on the left the dice coefficient, on the right the volume difference. And here we see, however, that the MP2 range, the acquired MP2 range, significantly improves the MP range results for both metrics. And also our synthetic MP2 range combined with the flare achieves very competitive metrics, which did not show significant differences compared to the real MP2 range. So we see that actually the MP2 range helps the delineation and the volume estimation of the lesions, but not their detection, at least in our dataset. So to conclude, first of all, some limitation, which I would like to point out. First of all, we applied our framework to a dataset which was acquired with one scanner and using a single imaging protocol. So we did not prove the generalizability of our GAN. Secondly, all MS patients considered were in the early stages of the disease and therefore had a quite low lesion burden. Therefore, more patients would be needed to validate it in, let's say, a larger and more diverse cohort. And finally, this framework really aims at improving the fully automated pipeline. So we generate the synthetic MP2H and then we straight away apply some automated tools and compare the results, segmentation results of this tool. We did not evaluate the clinical value absolutely of the synthetic MP2H. And some take-home messages. So we successfully translate MP2H images into realistic-looking MP2H ones for MS patients. Our visual analysis concluded that no artifacts were added in the generated images, and our synthetic MP2H images significantly improve the performance of automated tissue segmentation tools and also the lesion ones in terms of delineation of the lesions. Future work would include testing the framework on a larger cohort and possibly on data acquired with the Philips scanner, as well as tackling the issue of simulating the quantitative T1 maps of the MP2H as well. And this is all from my side. I would like to thank my supervisors or our collaborators, our funding source, and thank you all for your attention. And any question is very welcome.
Thank you very much for the talk, Francesco. Any questions in the audience?
Can I ask?
Go on.
Thank you very much for the great presentation.
Of course.
And I wanted to ask again the evaluation setup for the lesion segmentation, where you said you use some deep neural network.
Yes.
Can I ask on what you trained it and so on?
Of course. So this is a 3DUNet based network, and we had few cases. We divided our 36 testing cases of the GAN into 3 folds, and we just tested on 2 folds and trained on 2 folds and tested on the third one each time. This is a shallow 3DUNet with only 3 levels, so we were not observing high overfitting, but again, it's a quite limited amount of training data.
I see. So the training data was the synthetic MP2H images.
Sorry, it was not clear. We train with different combination. So as we can see here, so we train different models. One with the MP2H plus flare, another one with the synthetic MP2H plus flare, then third one with MP2H plus flare, and the last one with the DR plus flare. And those was done.
You test using the same images again.
Yes, exactly. We
tested
Thank you. Using the same ones, as the testing one of the GAN.
I have one question about actually the fact that the synthetic images improve the segmentation performance. So that's quite surprising, because one imagines that all the information that's needed for the synthesis is in the first image, yet we're not able to create a segmentation algorithm that does better than the synthetic image. Like, do you have any insights into that? Is that an optimization problem? Is that,
That's a good point. I mean, I don't have an answer, but I think it's reassuring somehow to see that the detection rate, it's pretty much the same. So we are not surely making up new lesions, or the network is not detecting new lesions that were not detected previously with the acquired MP2H. But I think it's really given by this the tissue contrast. So given that the synthetic MP2 range resemble more the MP2 range, the network is just able to delineate better the lesions in certain cases, especially for these large periventricular ones. But yeah, it's a very good point. Don't know, Mary, do you want to add something? Or yeah.
On that note, maybe I can follow up on this question. So, in the difference images you showed, that looked at the difference between the synthetic MP2 range and MP range.
Yeah.
It looks like your algorithm is able to take out the bias field as well to some extent.
To some extent, yeah.
Is that additional bias field, or did you already use bias field removal in the original MP range images?
We did not. So I used the bias field correction for the ants tissue segmentation, as it requires that the images have been previously corrected.
Yeah.
But I did not apply a correction before feeding to the GAN. I also experimented some bias field data augmentation to see if that would help removing more bias field. That did not bring conclusive results, but could be a way also to remove it more in the output. There is still some bias field remaining. You can also see maybe a bit here, slightly, difference in the white matter values.
Thank you.
Yeah, of course.
I would also have some questions, if I may ask.
Yeah, definitely.
So, very cool project and presentation, Francesco. I would have, let's say, questions in two directions. So first of all, you are generating images, right?
Yeah.
So then you are training a 3D unit for segmentation. How did you assemble afterwards the images into volumes?
Yeah, that's a good point. So we took, as I was saying, for training, we were taking 2D slices, well, patches from the three orthogonal planes. At testing time, I tested the GAN with slices extracted from the 3 planes. And then I just, for each one, reconstructed the 3D volume and averaged the probability, the intensity values obtained as output from the 3 orthogonal planes. So in this way, we should somehow ensure 3D consistency, even though the generator is 2D. Yeah.
Okay, thank you. Makes sense. I've been working with something similar, and trying to reconstruct 3D volumes. I had very high intensity differences between slices, so I had this difficulty. So I was curious how you overcame this. And another question would be: have you tried out simple pix-to-pix or compared against it, and why did you choose to stray away from?
Yes, yes, of course, we did a lot of. I don't have the results actually, but we did a lot of experiments. The main thing was actually the perceptual loss helped quite a bit, reducing this smoothing, this extreme smoothing. So the GAN was really tending to just smooth out the normal Gaussian noise present in the MP range input. So the perceptual loss helped quite a bit in this sense. And then I was mostly just reading some literature and added the residual blocks in the pix-to-pix architecture, as it was shown to help in some previous works. Yeah.
Okay, thank you.
Welcome. Yes.
Pochi, just go on.
Yeah, go ahead.
So I was wondering if the VGG19 in your network architecture,
yeah.
Oh, VGG16 is to
16, yeah, it's similar.
So it is used to like a classifier to segment the lesions in the brain. So I'm not sure what does this one do here.
Yeah, no. So basically, we took the pre-trained model. We pass the synthetic MP2H and the real MP2H images through only the first four convolutional layers, and then we compute an L1 loss between the feature maps of the fourth convolutional layers between the two images. So we don't. It's just.
Okay, so
We don't get to the output of the VGG. Yeah.
So this has nothing to do with the segmentation of the
No.
population.
No. So this helps only maintaining the visual appearance, let's say, of also the noise. Yeah.
Oh, okay, I see that. Thank you.
Yeah, you're welcome.
Hi, Francesco. I have another question.
Hi. Yeah, sure.
So you have paired MP range and MP2 range.
We do. Exactly. Yeah.
So, and that's why you can apply this L1 loss, right? So, I mean, that's nice, but your method can already work with unpaired images if you just remove this L1 loss. The other two losses can work on distributions, basically, right?
True. Yeah, that's correct. I didn't try it yet, but yeah.
Do you think
could be done? I mean, we could apply a sort of a cycled GAN as well if we think about unpaired images. Yeah. Also, because it's very rare to have a data set with both MP-RAGE and MP2-RAGE, because of course they are similar contrast, so they're not usually acquired both at the same time. So no, this could be a good expansion indeed.
And also, like a follow-up question on this, you have a fairly deep image-to-image translation network, which produces like the residual between the two contrasts.
Yeah.
And even though the network is quite deep, you basically model only contrast changes. You don't end up introducing any structures in the translated.
Yeah. Yeah.
The reason for this is the L1 loss.
I think so. Yeah. The goal is really just to make the network learn the mapping between the two. So in this sense, yeah, the L1 loss was probably the most obvious choice.
Right. Yeah, because please.
No, just to put a little bit more on the clinical context of this mapping. So the initial hypothesis is that this mapping would help in better detecting the cortical lesions. So this we didn't find out, because our idea initially was that as the MP2-RAGE has this better contrast and separation between gray and white, the cortical lesions are better identified visually by experts, so the network would do the same. But this didn't happen indeed. So this is just to put you in the context about the main hypothesis. Right. So basically what we understood is that it's learning a global mapping in between the two. It improves in the good way, removing a certain bias, splitting as well more he didn't show the histograms, but we saw as well how the image histograms of the synthetic images really fit well the image histograms of the original MP2-RAGE. But we didn't manage to get our initial hope that it would as well detect better than later on the lesions. So it's a general mapping, I would say, no new structures.
But yeah, at the same time, it's interesting to see that somehow the network is probably learning to segment cortical lesions in a different way compared to human experts. So it's already able to segment them well on a simple MP-RAGE images if they were labeled correctly. So our cortical lesions were labeled, of course, looking at the MP2-RAGE images, and then they were co-registered the segmentation to the MP-RAGE ones. So this is also, I think, an interesting point.
Yeah, that makes a lot of sense. Thank you.
Of course.
Yeah.
Thanks. I have another question.
Yeah, of course.
So you have these paired MP-RAGE and MP2-RAGE images.
Yeah.
So could it also be, obviously now, this is not the aim of what you've shown here, but could it also be conceivable just to train a segmentation network inputting the MP range images and using the segmentations from the MP2 range images, so that like the segmentation network would learn to go to the MP2 range segmentations using only the MP range images, and internally it would somehow learn to do this mapping.
Yeah.
And so on.
Yeah, definitely. I mean, we don't have necessary to do this in 2 steps. No, I completely agree. This could probably unified in a single generative and segmenting network. Yeah, it's a good point.
Your method obviously has additional advantages, but
yeah, no, but it's just a first step, so it's good. Yeah, that could be expanded in this way. Yeah.
So on that note, why don't they always acquire MP2 range, by the way? Why do they acquire MP range now? MP2 range is there.
Don't ask me. I don't know. I don't. It's the acquisition itself is slightly longer. I think 2 minutes or something like that. But the time, it's not really the reason, I would say.
There is a culture change that has to be done, and it will be in the future. Probably it still remains more research sequence than the clinical sequence. I imagine perfectly constraints on longitudinal studies where you don't want to change the sequence for sure. So I think it will take time that they adopt MP2 range. But I mean, but it's more philosophical question and asking the technicians and the neurologists and neuroradiologists to change their mind. Our collaboration with Basel, they are actually, if I'm not wrong, Francesco, correct me. Actually, they are only acquiring now the MP2 range.
Year, yes.
So they are very positives on that sequence.
But indeed, yeah, this tool could help also for studies considering data acquired in the last years where MP2 range was not considered. Could be a way of homogenizing the dataset, having a very similar MP2 range that can be compared with the ones that are acquired from now on, probably in the clinics, hopefully in the clinics.
Mm-hmm. Yeah.
Any other
just
questions?
maybe one more comment, maybe if you are not familiar maybe with the MP2 range, I never realized if someone is familiar or not with this sequence. This sequence started or was born on the 7 Tesla brain imaging because of the strong bias field in there. And then it swapped to the 3 Tesla. So it was coming from really a very advanced research sequence to the more clinical setting because of these benefits indeed. But this was why it was not originated from the classical clinical scanners.
Oh, I see. That might be the main reason.
Exactly. So it comes from another way around, right? It comes from the 7 Tesla research brain towards back to the clinic.
Yeah.
And it's quite new as well. I mean, it was developed maybe 8 or 7 years ago, I think. So it also takes time, I guess, to be adopted. Yeah.
Any other questions in the group? If not, I would like to thank Francesco and Miri. Thank you very much for this great talk.
Yeah, thank you guys. It was very nice discussions and
yes.
good ideas actually. Absolutely.